Sweet. So this obviously isn't. Oh shit. Right. This isn't an immunology class, right, guys? So you don't need to be really super familiar with all different types of immune cells and how they work and the different types of regulations. So I'm going to break this down for you in terms you guys need to know. Okay, so I think this is Dr. Z's first slide in this presentation. The numbers here are kind of important. You see some good trends here. What is kind of significant, there's about 120,000 people that could use some sort of transplant, but only about 80,000 of them are actually eligible due to either pre-existing conditions or like smoking history, things like that. So that's a pretty significant number. And the rest, you should just have a vague idea of sort of where they stand on the continuum. So just sort of be familiar with these numbers. This slide sort of goes on the different types of transplantation. Just be familiar with the red words. Obviously, likes the red words. Know those definitions. For the allogeneic transplants, we have living donor and cadaveric donors. Living donor, the classic example is a kidney, for example. That's what's being shown in this picture here, because someone can live with just one of their kidneys. One kidney is enough to restore pretty much normal renal function. And then xenogeneic, those are animal transplants, which obviously are a bit troublesome because the proteins between a cow and a human, for example, while they may be kind of similar, those differences are significant enough that they can cause severe rejections. So Dr. Z has a lot of stuff on MHC and HLA. When you see these terms, think of T cells. You don't really know much about what T cells are doing, but they're initiating the rejection phases. And when you sort of see this, think of T cell activation, that subsequent rejection isn't happening willy-nilly. What you need is to have a T cell, and then your antigen, and then a protein needs to coordinate the two together. So that protein is what we call the MHC/HLA. MHC is the very broad term that corresponds to like vertebrates across the board. The HLA is the human leukocyte antigen, which is just the same term but specific for humans. Right? Does that make sense? That refers to that protein that's mediating the connection between your T cells and the antigen. Good? So I have here MHC plus antigen equals immune response, specifically the T cells. And you have different types of T cell rejections. You have hyperacute, and chronic. And that's significant because you have, we've all heard of different blood types, whereas those are antibody mediated and it's only hyperacute. So that's just a difference you guys should note. So this is one of the classic experiments Dr. Z has. I tried to break it down here. The two brackets are what's important. On the first, you're just seeing one skin graft being transplanted to a completely different mouse with a different set of MHCs. So the compatibility isn't there. And what you see here is after about 10 days, that's what's on the y-axis, the rejection occurs and 100% of the animals will die, or not die, well, you'll have total rejection of that skin graft. And the other bracket on the right is showing if you take those activated T cells from, say, right around day 10 on the left bracket, you inject that into a mouse pretty much concurrently with that skin graft, and you'll see the y-axis get about halved, a little bit less than 10 there. And that's just showing that when you inject those activated T cells, that's what's taking so long in the first experiment, right? So those activated T cells happening concurrently with the procedure equals about 5 or 6 days for total rejection. Okay, so we have different types of rejection reactions. I mentioned the hyperacute, that's antibody mediated. The classic example is having, A-type blood mixing with B-type blood. Those antibodies are going to precipitate. You're going to have a hyperacute reaction. It takes about 48 hours, very quick. And then you have the acute rejection and then chronic or late acute rejection. So a good way to think about those two differences are with those HLA molecules. When you have the HLA/MHCs coordinating your antigens with the T cells, you're going to get the direct pathway. When you don't have those proper MHCs or HLAs, which are just that protein that's coordinating that reaction, you need a different type of antigen presenting cell. You guys don't need to know what kind of cell that is, but that's taking a little bit longer. That's the indirect pathway. Does that all make sense? And then graft versus host reactions, that's kind of the opposite, where your actual graft is what's going to cause that rejection to the host. And there's a good definition there right in your guys' slides as well. And then testing for a match. So right now we have good technologies and therapies and medications that can reduce chronic rejection. There's not really much you can do right now about hyperacute or just regular acute reactions. The only way we can prevent those from happening is having these concerted tests that can match whether these different tissues will be compatible or not. And it is just listing some of those tests. You have blood tests determining if you have different A, B blood, A or B, O blood. Stimulation of mixed leukocyte culture. You don't really know what these tests are, just know that they exist and what they're sort of accomplishing. DNA typing. So just know the red, right? And then on that same note, these are some more definitions that obviously has specifically for how transplants are regulated in the United States. I should be familiar with, these aren't red in the PowerPoint, but they're red in y'all slides. The Uniform Gift Act is certainly significant, which goes sort of in line with their required referrals and the OPO. It's also a part of it. So I'll definitely refresh on those groups, right? And then moving right along, this is, so you guys had an article that she has highlighted and also the documentary. I would recommend maybe re-watching the documentary, looking over your notes, looking over friends' notes. You don't really need to get specific details from the documentary, but just sort of how it all coalesces is very important. And you know, if you have a good idea about how all this works, you'll be fine, but maybe if you have time, take a look at the documentary. This article I recommend rereading or reading it for the first time if you haven't done it already. It's not too long, it's pretty short, and it's pretty interesting. It's just sort of showing how the supply is not meeting the demand. And as a result of that, we have things like illicit trafficking of organs or just outright stealing of organs. And there's national disparities between, you know, some countries are handling these issues better than others. Dave, you're familiar with how that all is working out. And that's it for transplants. Any questions? Nope. Sweet. Yeah, sorry.
On slide, I think it was the first slide.
The one I did?
Yeah. You don't have to, okay. It says 18,000 transplants before this year, but in her kidney transplant lectures, it also says that 18,000 kidney transplants are performed a year, and so what?
Yeah, these fellas. She's saying that this number here is 18,000 is, I don't think it's important.
We'll check on it, we'll let you know.
Yeah, okay. Anything else? All right, we'll get back to you. All right, so yeah, for the sake of the exam, don't worry about that disparity. We'll catch up with Dr. Z. We don't really know which one's correct. Yeah.
So next we're going to talk about kidney function and dialysis. So the kidneys are obviously a really important organ. Like, they perform a lot of different functions, including excretion of detoxified compounds, a ton of regulation, and they secrete renin. This chart was like a filtration and reabsorption chart that was in her slides, and it just goes over like the amount of all the different liquids and solutes that the body filters, excretes, and reabsorbs. I would note that water, 180 liters of water is filtered per day. So kidney disease is diagnosed when there are elevated levels of urea and creatinine in the plasma, which is just blood. And this is measured using clearance. So that's just the quantity of the solute that's produced in the urine over time over the total blood concentration. So that's just an equation that they use to calculate clearance and determine like whether or not the levels of urea and creatinine are in line with normal homeostasis or if they're out of balance. There are 3 risk factors that can lead to compromised kidney function. And these are diabetes, obesity, and hypertension, which is the cardiovascular disease. So kidney failure happens when the kidneys can no longer support life. And there are 3 different treatment options to address this, and those include hemodialysis, peritoneal dialysis, and transplantation. So in terms of hemodialysis and peritoneal dialysis, there really isn't much of a difference in terms of which procedure provides like a better outcome. It's really up to the patient and like the doctor based on like whichever treatment is preferred. This is just a picture taken from the slides of the differences between the 2 types of dialysis. So in hemodialysis, there's like a graft or fistula that's usually inserted into the forearm, and that's connected to a dialyzer that filters and reabsorbs all the different necessary solutes from like the, I guess you could say like infected blood, and then that just feeds like good blood back into the circulatory system. And then with peritoneal, and then peritoneal dialysis, it's the same overall idea, but just the mechanism that is used is different. So the cost of dialysis can be expensive, and a lot of this burden is covered by the government. The average cost for Medicare patients to undergo dialysis is $70,000. So for hemodialysis, vasculature access is really important since that's what's kind of connecting the body to the dialyzer. So there are 2 different types of, there are 2 different ways to gain vasculature access, and those are the AV fistula and the synthetic vascular graft. With the AV fistula, it's sort of like a port that connects the artery to the vein, which allows more blood flow into the vein and creates a stronger, larger artery. And that's good in terms of repeated needle insertions. And then for the synthetic vascular graft, that's just implanted into the body of the patient. It's more used for patients that have small vessels that aren't really able to like withstand like repeated needle punctures. Yeah.
Why couldn't you access a large vessel? Why do you have to do a fistula instead of accessing a larger vessel?
Well, you're connecting like the blood from that goes like the blood flow from the artery to the vein directly. I don't. You mean like choosing like the carotid?
Yeah, for example.
I mean,
Super dangerous.
yeah, you have to do this over and over and over again, you know, at least 3 times a week. So, I mean, you don't really want to put these important vessels at risk. Even if they're not, you know, immediately at risk while they're in there. You know, you want to be able to move, right? So if you put something in like your femoral or your carotid artery, like you're stuck in that same position for hours. You might damage the vessel enough after so many pokings that, you know, you're at risk for an aneurysm where it might go and just burst on you. I mean, it's also just straight up convenience. I mean, the arm isn't, once you create this fistula, the arm is an easier access point. And, yeah, I mean, a lot of it also probably has to do with pressure. You know, different amount of pressure, different places in the body, you want to blow the needle out or mess with the machine. Over time, this is just effective for a variety of reasons.
Also, ideally, you want it in a vein because it's going to be deoxygenated blood and it's already going to go on through your tissues. So what you do, you know, you're going to make a vein, you're going to actually remodel the vasculature, and it's going to be actually thicker than an artery, where it can be something that you can poke consistently, you know, throughout the years. So
Thank you.
Yeah, so then these are just pictures from your slides that show the 2 different types of ways to get vasculature access for hemodialysis. So a dialyzer is the actual machinery that filters the blood back into the body, and those components include a fluid cycler, the dialyzer membrane, cartridge, and dialysate fluid. And this picture is also from your slides. So there are 3 different ways that filtration occurs, and that the dialyzer is able to exchange the appropriate amounts of solutes between the filtered and unfiltered blood. So diffusion removes excess electrolytes, so that's like salt, ions, potassium ions. Convection removes smaller molecules, and ultrafiltration removes water. So, as I mentioned before, elevated levels of urea indicate kidney disease. So this molecule is kind of used to quantify how successful the dialysis session was. This molecule is generated from the breakdown of protein, and its concentration decreases during dialysis, so it's being removed from the blood, and it increases in between treatments when the body